Welcome back to your Pediatric Dentist channel, Tiny Theatre Talks. If you are new to this channel, subscribe the channel, and for details of this channel, visit the bio section, or you can also check out my previous videos. From today onwards, we are covering one of the most important topics in pediatric dentistry, behavior management techniques. So first, subscribe and press the bell icon to get notification timely. These all are important definitions starting with the behavior and behavior management, and we generally modify the behavior by behavior shaping with proper guidance in behavior management, and all these things are done by us in children, so that's why it's called behavioral pedodontics. So first, why we need to do the behavior management? What are the aims behind? Although the operative dentistry may be perfect, but appointment is a failure if the child departs in tears. So for those who exhibit considerable anxiety or problematic behavior, child behavior management is there, which requires skills in expressive communication, empathetic listening, and coaching. So, the aim of behavior management is to instill a positive dental attitude and create a long term interest on the patient's part so as to facilitate ongoing prevention and improved dental health in the future. So, starting with the definition. First is behavior. Behavior is an activity that can be observed, recorded, and measured. It is an observable act or any change in the functioning of an organism. Then, behavior management. So, according to Wright in 1975, behavior management is the means by which the dental health team effectively and efficiently performs treatment for a child, at the same time instills a positive dental attitude. How we instill positive dental attitude? We can instill a positive dental attitude with the behavior modification by behavior shaping and guidance. So behavior modification. So according to Eysenck in 1964, behavior modification is defined as the attempt to alter human behavior and emotion in a beneficial manner according to the laws of modern learning theory. Here, according to the laws of modern learning theory, means it include classical and operant conditioning, which is mainly focused on conditioned behavior. So here the main thing is conditioned behavior. So we generally shape the behavior, and from that the next is behavior shaping. So behavior shaping is the procedure which slowly develops behavior by reinforcing a successive approximation of the desired behavior until the desired behavior comes into being. For example, desensitization, tell show do, modeling, distraction, contingency management are the techniques for the behavior shaping. Then behavior guidance. Behavior guidance is a continuum of interactions involving the dentist, dental team, patient, and the parent, directed toward communication and education, which ultimately builds trust and allays fear and anxiety. Then behavioral pedodontics. So behavioral pedodontics is the study of signs that help to understand development of fear, anxiety, anger, and associated acts as it applies to the child in the dental situation. So by understanding all these, we can apply the behavior modification by shaping and guidance. What are the main objectives of behavior management? So according to Snoder in 1980, the objectives are to establish effective communication with the child and parent, gain child and parent confidence for dental treatment, teach child positive aspects of preventive dental care, provide a comfortable, relaxing environment to the child. Here are some factors influencing child behavior in dental office. We will not discuss it in a detail because some of them are already discussed in detail previously. I will take all the videos that are connected to these. Wright summarized the following factors starting with the medical history. So if the child's previous visits or visit to the physician was fearful or unfavorable, then it will affect on the dentist visits, and if it was favorable, then child have less apprehension. Then maternal anxiety, we already talked about it in a previous individual video explanation. Family and peer influence. So socio-economic status of the family directly affect the child's attitude towards the value of the dental health process. Those of a low socio-economic class, below average education, have a tendency to attend dental needs when symptom dictates. These families harbor anxiety from dental treatment, and these children take on this fear and tend to be less cooperative. On the other hand, if financial and educational means are ample, families value good dental health easily established in preventive program. Dental office environment, we already talk about it in a separate video explanation of first dental visit. Then growth and development, younger the child, more atypical will be the response. The intellectual age of 3 years signifies a maturational readiness to accept the dental treatment. Personal factors, temperament, and general fearfulness are some personal factors which are also influenced by environmental factors. And what are the environmental factors? Various environmental factors like age of the child, socioeconomic status, family situation, frequent exposure to invasive medical care, past experience of operative dental care, etc., have been identified to influence the child's behavior. However, parental dental fear has been noted to be the most influencing factor amongst all the environmental factors. And other variables, Stephen V explained that many other variables affect the child in the dental office, like socioeconomic status, culture, sex, sibling relation, number of children, presence of parents, and attitude of dentist. Now, here are some classifications of child's behavior in dental office you need to know and you have to learn. So first classification is Lemsir classification. So Lemsir classification was given by Lemsir in 1970. He divided the child's behavior into 8 categories. The first is cooperative. Children who remain physically and emotionally relaxed and cooperative throughout the entire visits regardless of treatment undertaken. Tense cooperative. Children who are tense but nevertheless cooperative. Outwardly apprehensive. So, child who hides behind the mother in the waiting room use stalling techniques. So, stalling techniques are the method used to delay or postpone an action, decision, or event, and the purpose of stalling is to buy time so that there will be change in circumstances, avoid an uncomfortable confrontations, etc. Then fearful. Children who require considerable support in order to overcome their fear of dental situation, and modeling is used for them. So for example, watching parents and siblings on dental chair with a positive attitude, or watching videotape or audio tape. Stubborn or defiant. Children who passively resist or try to avoid treatment by using techniques that have been successful for them in other situations. So they are able to cooperative but they won't. Hypermotive. Children who are agitated and who adopt procedures such as screaming or kicking as their coping defense mechanism are fit in the category of hypermotive. So basically, hypermotive child is who exhibits excessive, exaggerated, and often uncontrollable emotional and physical reactions to stimuli, particularly stress, fear, or discomfort. Handicap. Children who are physically, mentally, and emotionally handicapped. Emotionally immature. This category includes the young children who have not yet achieved sufficient emotional maturity to rationalize the need for dental treatment and to cope with it. So, in psychology, emotional immature children are 0 to 5 years of age, and in pediatric dentistry, the age range is 0 to 3 years. Then, the second classification is Pinkham's classification, given by Pinkham in late 1970s or early 1980s. So, the first category is emotionally compromised child. So, this category includes children whose negative behavior stems from fear and anxiety, making them timid or shy. Means they may enter the operatory cautiously, avoid eye contact, speak softly, or be very reluctant to open their mouth. And we have to build the trust and rapport first with the different techniques to overcome their fear. Then the second is shy introvert child. So they are passive patients who follow directions but show no enthusiasm or interest. They often sit still and quietly, making them outwardly appear cooperative. They may not readily respond to the questions or engage in conversation. So we have to establish a calm, non threatening atmosphere. First, using calm communication and positive praise is essential to help them gain self confidence. Category 3 is frightened child. So, this category is categorized by a child who has extreme acute anxiety or a phobia related to dental visit, and their fear leads to strong outright resistance, such as a loud crying, forceful refusing, kicking, flailing of the hands and legs, sometimes called uncontrollable behavior or tantrum. It requires strong behavior guidance and voice control to gain attention, protective stabilization for safety, or pharmacological methods are used to allow treatment. Then category 4 is child who is adverse to authority, means same stubborn or defiant child. This category includes children who have the cognitive ability to cooperate but choose not to. Their behavior is a challenge to the dentist authority. They use phrases like I don't want to or you can't make me. They try to dictate the situation, give orders, or actively push away instruments. This behavior is more common in older preschooler or elementary school age group who are testing boundaries. And the third one is Frankel's classification. Frankel in 1962 introduced a behavior rating scale, which is one of the most reliable tools developed for behavior measurement. This consists of a rating of determination numbered from 1 to 4, and each define a specific behavior. Then Wright in 1975 suggested that a symbol to be added to this rating scale, permitting the dentist to record a behavior base at the inception of the dental treatment and keep a progressive record of the child's behavior. And then he gave the symbol to Frankel's four type of behavior, and they also gave a right sided arrow mark indicating the change in the behavior in dental operatory due to fear or behavior guidance. For rating number 1, the behavior is definitely negative and two minuses are used, and the features are refuse treatment due to immature behavior, cannot reason or cope with the situation, uncontrollable behavior, temper tantrum suggestive of extreme anxiety, defiant behavior, exhibit resistance, cries forcefully, uncontrollable behavior. And extreme negative behavior associated with fear also include uncontrollable behavior in older children possessing deep rooted emotional problems, and defiant behavior include passive resistance in the individual approaching adolescence. These all features are included into definitely negative behavior. Then the rating number 2 is negative, only 1 minus. So reluctant to accept treatment. Here reluctant to accept treatment describes a state where the individual is present and aware of the need of treatment but express their negative feeling through hesitations, passive resistance, timidity, or emotional withdrawal rather than overt defiance or aggressive. So immature behavior, timid behavior, basically seen in the children who are overprotected, exposed to few peoples, or dominated by strange environment. Timid means basically a shy behavior, shy nervousness or hesitations, particularly in the presence of unfamiliar people, situation or challenges, and displays evidence of slightly negativism with the timid behavior and winning behavior. All these features are included into negative behavior. Then rating number 3, the behavior is positive. 1 plus sign. Children who accept treatments like tense cooperative behavior observed in all stages. They are tense but ultimately cooperative. Conservative behavior respond harmoniously. Timid behavior follow dentist direction in a shy, quiet manner can become uncooperative due to any bad experience during treatment. And the rating number 4 is definitely positive, include double plus. Unique behavior looks forward to understand the importance of good preventive care and establish a good rapport. Then the rights classification in 1975. So they classified the behavior into four types. First is cooperative behavior, which is generally cooperative. Then lacking cooperative behavior means this category includes children who genuinely cannot cooperate, usually due to their stage of development or specific condition rather than a refusal to cooperate. Then potentially cooperative behavior include the incorrigible or uncontrolled behavior. Incorrigible means very bad, too bad to be corrected or improved. So this is typically presented by 3 to 4 years old children at their first dental visit or by older children at the time of injection. There is a loud crying, kicking and temper tantrums. These children fall under the hypermotive category of Lampsir. Then the defiant obstinate behavior. So this child has been termed as a spoiled kid by Lampshire in 1970. He controls his behavior in a sense by challenging the authority of the dentist. Typically responses are I do not want my teeth fixed or you cannot make me open my mouth. These children have potentially severe emotional problems that are manifested at home, school or other areas of life. Timid behavior often expressed by young children, particularly at the initial dental appointments. It is a result of child's anxiety about the dental experience and how he is expected to perform in the office. The child's anxiety may prevent him from listening attentively to the dentist, so instruction must be given slowly, quietly, and repeated when necessary. Once the child gains confidence in the dentist, he can become excellent patient. Tense cooperative borderline behavior. They are extremely tense. Body language is different. Tremor in voice, sweating palms, hands. They can be cooperative if behavior managed well. And winning behavior. The child with this type of behavior can be extremely frustrating to treat. He allows treatment, but he wins throughout the entire procedure. Then the stoic behavior. So stoic behavior is a type of behavior commonly mistaken to be a part of potentially cooperative group, but this child is generally cooperative, sits quietly, accept all the dental treatment including injections without protest or any sign of discomfort. This behavior is characteristic of children who have been physically abused. Till now we saw the classification of behavior. Now this is the classification of behavior management techniques. Basically two type of behavior management techniques, non-pharmacological and pharmacological. In non-pharmacological there is a psychological approach and physical approach. So psychological approach include these techniques and physical approach include these two technique. And then pharmacological include the pre-medication, conscious sedation and general anesthesia. And we will start with non-pharmacological behavior management techniques from next video, and all the techniques will not be covered in one video. So make sure to subscribe the channel and press the bell icon for timely updates. So these are the references, and if you want this PDF or any other PDF, like, share, subscribe the channel. New videos on Sunday, and we are uploading topic of the week shorts which are very important for your revision and competitive exams. Thank you.